Okay. Good evening and welcome to the first nanoTalks of this year. My name is Celine and I organize this nanoTalks together with my coach Vanessa. Today we will discuss the fascinating topic of gender medicine. But before we will dig deeper into that, I want to introduce you to REACH, the organization behind the nanoTalks. REACH is a young Swiss-based think tank with the device Research, Think, Change. We want to bring science, society, and politics together to find the best solutions in our world. There are four main activities how REACH want to do this. First of all, there is the REACH blog. There, young scientists can write articles and explain topics to a broader audience in an understandable way. There's also the podcast Weiterwissen in German. Moreover, we organize evening events like the one you're attending right now. There exist different formats from small gatherings to big exhibitions where we want to reach people to talk about different scientific topics. And finally, REACH is also making policy recommendation, mostly through the Francini project. I am part of the SIMPACT program offered by REACH. SIMPACT is a training program for young people who want to bring science into public debates. You can attend different workshops and social events to connect with others. And we also have a coach, in my case, Vanessa, who helped me with the organization of this specific event. And if you're interested in our activities, the SIMPACT program, or want to learn more about us, then please visit our website or follow us on social media. We are a grassroots organization, so stay in touch with us, or even better, get involved. We are currently over 300 members all over Switzerland. But now let's start why we're here today, to learn something about gender medicine. nanoTalks means that we'll have two interesting talks from young scientists with a discussion afterwards. Personally, I wanted to talk about gender medicine for several reasons. First of all, it's a perfect example of how science and societal beliefs are intertwined. We will soon learn more about this in the talk of Sarah. Moreover, I always wanted to learn how you conduct studies in the field of gender medicine and how you apply this knowledge into medical treatments. And finally, I wondered why gender medicine is a concept that is often misunderstood and interpreted in a wrong way. In the following two 15-minute talks from Sarah and Nida, they will give you a good overview of this fascinating topic. And the best thing is that you can interact with the speakers and always ask questions during their talks on the website Slido with the code nano-jan. After the two talks, I will ask you questions to the two speakers in the Q&A session so that we have the chance to hear the answers from our experts in the topic. And now I want to introduce our first speaker, Sarah. Sarah Scheibmantel studied Media and Cultural Studies, as well as History of Science in Weimar, Berlin, and Cambridge, UK. Since October 2019, she has been a research assistant at the Department of History of Medicine at the University of Zurich, where she's writing her doctoral thesis. In doing so, she's asking herself how the development of the early vibrator influenced concepts of femininity around 1900. The question of sex and gender not only comes up in her work and in teaching at the medical faculty, but as a feminist, she's also privately interested in the topic. So, Sarah, the stage is yours.
So then let's start. A friend of mine had pain in her abdomen. It was Sunday, all the doctor's surgeries were closed, but the pain was so bad that she went to the hospital. The attending doctor in the emergency room asked her if she was sure she wouldn't just get her period soon and sent her home with a painkiller. How the story ends should not be important at this point. However, what is important is that the phrase, "Are you sure you won't just get your period?" or "women are more sensitive than men," lead to women being treated wrongly or not treated at all every day. My story is not an individual case, it has a system. And this system is historical. I want to show you how little neutral medicine has been historically and why women in particular have suffered from it. I would like to start with a content note. Some of the practices I mentioned were violent and did not always take place with consent. In a second part, I would like to use what we know from history to argue why it is not sufficient to think of medicine in binary terms today. As it is relevant to this argument, I would like to say 2 sentences about the term woman. I use this term historically, which is social, cultural, and biological dimensions are attributed, not as a fixed nature. Gender identities are more diverse. Not all who have been socialized and assigned female always and exclusively identify as women. Much more, gender has been and continues to be normatively defined. But let us first turn to history. Gender binarity is a construction of the 18th century. Before that, the male and female body were assumed ultimately one and the same body. The historian Thomas Laqueur speaks of a one-sex theory. The female genitalia was an inverted penis, which was based on the fact that men were hotter than women and that their sex was thus turned inside out by the heat. From this was deduced that men were giving and women were taking. Nevertheless, or precisely because of this, both male doctors, by the way, all doctors were men unless I explicitly emphasize otherwise, and midwives believed that the female orgasm was important for reproduction. In terms of orgasm, women and men were on the same level, but the scientific languages, so they were on the same level, but the one-sex model also meant that until about 1700, there was no term for the vagina, either in the scientific languages Latin and Greek or in European colloquialisms, as it simply seemed to correspond to the male organ. Thus, the female genital was given equal rights in that orgasms were recognized as equally relevant to survival. At the same time, it was made invisible by not being given a name of its own and thus not considered something separate. Around 1800, a radical break occurred and the female body was understood to be the opposite to the male. One speaks of a two-sex theory. The idea that women had a completely different body than men led to an intensified examination of the female body, the so-called dark continent. However, medicine served to manifest social structures. For not only speaking, but also medical practices are never neutral. In the following, I will show you what I mean by this. Many doctors in this period referred to the nerves, which were heavily researched in the 19th century. Nerves were assigned to various diseases that had already existed for centuries. Hysteria deserves special mention, which shows as well the construction of female bodies and their so-called abnormalities, as well as the role of society in medical practice, as for medicine has been organized around a phallogocentrism since its beginnings. Hysteria was already known since the ancient Greeks, when it was believed that the uterus wandered around in the body and in the worst case settled in the brain, case of hysteria. This symptom could be only reversed by penetration of a penis. The assumption of what hysteria was evolved over the centuries. Particularly in the 19th century, hysteria experienced a new surge of knowledge when almost any so-called abnormal symptom could be defined as hysterical. The Frenchman Jean-Martin Charcot in particular researched in the Salpêtrière, the best known asylum of the time, where Sigmund Freud also interned. Charcot relied on the nerve theory, and since hysteria occurred mainly in women, it was believed that women had weaker nerves than men and could accordingly become ill more easily. Hysteria was declared to be a neurosis that was closely related to sexuality. Because of their weak nerves, women would be more aroused by sexual activity, which would become the main cause of nerve suffering. Masturbation, in particular, stressed the nerves so much that women could become hysterical. Medical research reinforced what late 19th century society had long known about women. Women were more dispassionate about their sexuality than men, as psychiatrist and neurologist Richard von Krafft-Ebing described in his standard work, Psychopathia Sexualis of 1886. Quote, "Without doubt, the man has a more lively sexual need than the woman. The woman is different. If she is spiritually normally developed and well brought up, her sensual desire is small. If this were not so, the whole world would have to be a brothel and marriage and family unthinkable." To him, the central point of female sexuality was love. Lust and passion were largely denied to women. This theory was particularly noticeable in the study of orgasms. Unlike 2 centuries before, the female orgasm was declared unimportant for reproduction. It was either annihilated or pathologized, as female sexuality was considered to have little variability. Especially too much drive was problematic. It was even worse when it led to masturbation, which is why various doctors took care of it. 2 famous men taking care of it were the US-American John Harvey Kellogg and the London physician Isaac Baker Brown. Kellogg was director of the Battle Creek Sanatorium and developed various therapies to help people lead healthy lives. Among this, together with his brother, he developed Kellogg's cornflakes. As he was a strict opponent of sexual excess, these were supposed to help against masturbation. Furthermore, he recommended in his book, Treatment for Self-Abuse and Its Effects, for women, quote, "The author has found the application of pure carbolic acid to the clitoris an excellent means of allaying the abnormal excitement," quote end. Baker Brown, on the other hand, stated in his 1866 booklet, quote, "Long observation convinced me that a large number of affections peculiar to females depended on loss of nerve power, and that this was produced by peripheral irritation, particularly the incident nerve supplying the clitoris," quote end. He derived the treatment of clitoridectomy, the removal of the clitoral glands. He saw female masturbation as causing diseases such as hysteria and epilepsy. He emphasized that the women were subsequently marriageable. Here we see the pathologization of female sexuality served mainly to lead a life of marriage. Baker Brown's methods, fortunately, did not last long. He performed some of the operations without consent of the patients, which ultimately led to his expulsion from the Obstetrical Society of London. The question of the role of the clitoris is something we can well glean from the research of the 2 gentlemen mentioned. The knowledge of the function of the clitoris was definitely there. In some books around 1900, as we can see on the left down, the clitoris is depicted as a structure with thighs, similar to the model we know today. The fact that knowledge about the clitoris fell into oblivion and was only brought out again in the 1990s by urologist Helen O'Connell was, among other things, due to the work of a gentleman whom I've already mentioned, Sigmund Freud. Freud developed psychoanalysis, abandoning the Cartesian paradigm that had prevailed for centuries. This led to the fact that physical symptoms could also have a psychological cause. At the same time, Freud was a child of his time. Biologistic assumptions about what women were inscribed in his theories, penis envy, for example. Particularly in relation to sexuality, Freud developed a model that persists in the minds of many to this day. The difference between the clitoral and the vaginal orgasm, whereby the clitoral orgasm is an infantile orgasm and the vaginal orgasm is an adult orgasm. But let's face it, the only real difference is that the clitoris is stimulated once at the glans and the other time from the inside at the clitoral thighs. And many people with vaginas reach orgasm more easily via stimulation of the clitoral glands. Poor Freud, he was simply wrong. And yet his assertions have burned themselves so firmly into the minds of many people, and it is stylized as a problem if vaginal orgasm is not achieved through penile penetration. There is a system to it. Telling women wrong things about their bodies were usually not, I'll call them carefully, evil intentions. Rather, medicine placed itself at the service of society. First of all, it is simply easier to research one's own sex. A recent Canadian study shows that women who are operated on by a male surgeon are 15% more liable to suffer a bad outcome and 32% more likely to die when a man rather than a woman carries out the surgery. Secondly, the societal roles of men and women were much more cemented than today. Medical research was supposed to prove why men and women were different, and therefore one sex had privileges over the other. The best example of the medical argumentation of social realities is the debate on women's suffrage, in which the professor Friedrich Sigismund was one of the main protagonists of the opposition. In his 1912 book Frauenstimmrecht, he compiled evidence to show that women were not competent to vote. In addition to common arguments that women were simply not interested in politics, he did not omit medical biologistic arguments for physically, or quote, for physically men and women are two creatures separated by an abysmal gulf, and that this difference is based on a law of nature. He continued, quote, the spiritual individuality of women, as well as their predominant emotional life, make them little suited for active participation in public life, to the man the state, to the woman the family. Women were accorded less due to their anatomy, which represented a deficiency or incompleteness. Conversely, the argumentation also shows the problematic image of men at the time. Men were supposed to be the strong and the leaders. After the First World War, the prevailing image of men began to falter. Many came back as invalids and war tremblers. The loss of male strength found a disease, neurasthenia, which described sexual hypofunction. Neurasthenia can be understood a bit like the opposite of hysteria, although the categorization was much more complex in those days, and both diseases could affect both men and women. Nevertheless, hysteria and neurasthenia are less actual illnesses and much more the expression of certain gender images that shaped the society of the time and needed legitimization. The gender images evolved is shown by the theory of the Dutch gynecologist Theodor Hendrik van der Velde. His book, The Perfect Marriage, enjoyed great popularity in Europe in the 1920s. He recommended to husbands, quote, the simplest lubricant to replace the missing mucus during stimulation play is saliva. If the absence of mucus secretion persists despite the stimulus exerted, the wetting with saliva must be repeated often. The associated inconveniences are of course omitted if the transmission takes place directly through the mouth, which happens with the stimulus kiss. Does this clear recommendation for cunnilingus explain the success of the book? We will never know. Van der Velde shows that on a sexual level, a lot was happening in the theory of medicine. Men and women were understood as consisting of the same predispositions. Nevertheless, the male body became the standard medical body. Unlike Magnus Hirschfeld, who already in the 1920s developed an intermediate model and a third sex, medicine was oriented towards a binary gender model in which women were considered deviations. We have seen historically how strongly women were pressed into a gender that was devised by society and legitimized by medicine. Even today, such biologistic models still hold sway. Remember my opening example? The argumentation of how women are generally more likely is exactly such an argumentation. In this debate, it is much more important to recognize female bodies not as biologically different, but as actually biological different. Even though feminism demands gender equality, it is on a medical level important to be seen different in an authentic way. And however, and here I take up again my definition from the beginning. Who are women? Who is allowed to call themselves a woman and who's not? I don't want to belittle the fact that it is a problem that medicine in general still focuses not enough on women. Rather, I want to reinforce that the problem is more complex than just talking about women and men. This puts us in the middle of the debate about sex and gender. There are not the men and the women. Gender as a category is very important to recognize. Nevertheless, on all the websites on gender medicine, I encountered only two genders, the female and the male. It was not entirely clear to me who was being referred to as woman. Is it about biological sex? This refers to the objectively measurable organs, hormones, and chromosomes. There are female, male, and inter, which is a combination of the two. In Germany, scientists estimate that the proportion of intersex people to be between 0.021 and 1.7%, depending on which forms of intersex are counted. Intersex is a spectrum and has always existed, but has been made invisible and pathologized. Up until the 1970s, sometimes even still today, intersex children often undergo genital surgery early after birth. Or is it about all those who define themselves as women and their gender? Gender identity describes how you think about yourself. It is the chemistry that composes you, for example, hormonal levels, and how you interpret what that means. There are also people whose own gender identity does not match the sex assigned at birth. These are trans people. To make gender identities even more complex, there are also people who define themselves as non-binary. Why am I listing all this? Yes, women have been and still are disadvantaged in research. However, the field is thought too small. We are only talking about women and men whose definition is not very clear because not all women have a uterus and not all men have a penis. I know that some of you now will say that the examples I'm giving here only concern a small part of the population and that the majority of people are cis female or cis male. As a feminist, I find it important not to argue only on the basis of biology, because those who do so deny some people their self-determination. That this denial is not feminist can be seen in the current German debate of a trans member of parliament against an article in the magazine Emma. Also, we still cling to the binary model of the 19th century, and we have seen what a certain norm setting and connection with social assumption does to people. So, if we are going to establish new norms, why not establish norms that actually correspond to what we know today? It seems to me that sex and gender are often mixed up in the medical field. We should look more into this and ask, is the problem a biological or a biologistic one? Gender medicine should take its gender claim seriously. It is not only about cis men and cis women, but also, to quote Magnus Hirschfeld again, about intermediate stages. Neither sex nor gender are binary. Medicine should recognize this and research should develop towards it. We act as if gender is clear and natural, but especially with today's medicine, we intervene in our bodies and change them, even hormonally. I would therefore like to conclude with a thought exercise I have from Catherine Malabou. Isn't a cis woman always already a trans woman if she takes the pill or hormone substitutes during menopause? Thank you very much.
Thank you, Sarah, very much for your talk. It was very interesting. And to the audience, please feel free to ask all the questions that you have specifically to Sarah. You can do that on Slido. And now let's go on with Nida. I think you will introduce yourself.
Okay, just gonna share my screen. So good evening, everyone, and thank you for welcoming me to this talk. And also thank you, Sarah, for this fascinating presentation about sex and gender in the history of medicine. So as for me, I will walk you through the role of biological sex, in particular the female sex, in the development of heart diseases, and especially in the interaction between the brain and the heart. But before we start, a few words about me. So I'm Nida Mikhail. I'm a medical doctor. I'm specialized in a branch of medical imaging called nuclear medicine. So why nuclear medicine? Because basically we use radioactive substances to explore how the organs function. And I moved last year from Paris in France to Zurich to conduct a research project about the differences between women and men in the development of heart diseases, and we are especially interested in the impact of mental stress on the heart. So why is this topic important? So there is increasing evidence that the rates of heart diseases differ between women and men, which suggests that the biological mechanisms that lead to heart diseases might also differ between sexes. And understanding these biological differences could help us to actually improve the treatment based on sex, and therefore to reduce and alleviate the burden of heart diseases. And in addition to biological sex, gender as a psychosocial identity, as Sarah just explained, regardless of the biological sex, could also impact the cardiac health. Another factor which has a detrimental impact on the heart is mental stress. But what is not known is if there are differences in the impact of stress on the heart of women compared to men. So in this presentation, I will walk you through what is known about the biological differences in the development of heart disease and what we are trying to understand, especially in relation to mental stress. So heart diseases remain among the leading causes of death in the world, and important diagnostic and therapeutic advances have been made in the last decades, but women seem to benefit less than men from these progresses. So as you can see here on this figure, the overall mortality related to heart diseases is about 40% in men and 49% in women, which suggests the existence of female-specific mechanisms leading to heart diseases, or at least to differences between men and women in the development of heart diseases. And the problem is that no clear explanation for this difference can be drawn from the available literature, mainly because the vast majority of studies have been carried out in men. And there is therefore an urgent need to include more women in clinical studies. So the sex differences in heart diseases have biological basis, which mainly relate to three pillars. First of all, the nervous system, in particular, the nervous system of the heart, which is called the cardiac sympathetic system. Also related to sex hormones, so testosterone for men and mainly estrogen for women, and also to the inflammation within the body. So all these three biological mechanisms can differ between sexes and are labeled sex-related differences. But on the other hand, there are also differences related to the female identity or to being identified as such, which are labeled gender-related differences. So first of all, the cardiac sympathetic activity. So the way the heart beats, its frequency, the strength of its contraction, etc., is controlled by a part of the nervous system, which is called the cardiac sympathetic system. And the nervous system of the heart can be explored with the nuclear medicine technique that is shown here. And basically, the more the nervous system of the heart, the cardiac sympathetic system, is activated, the more the color will be intense on the image. And as you can see here, for example, in young males and older males, the level of activation of the neurological system of the heart, the cardiac sympathetic activity, is comparable. Whereas when you look at young women, especially before menopause, and older women, especially after menopause, we observe an increase in the activation, in the activity of the cardiac sympathetic activity of the neuronal system of the heart. So why is this important? So if we look at the left part of the image, which is related to women, we see that, actually here, what is represented, women with increased activation of the nervous system, so with an increased cardiac sympathetic activity, are shown here in red. And women without this increased activity of the cardiac sympathetic system are shown in black. And the lower this curve gets, the more people experience heart diseases and complications. And so what we see here is that women with increased nervous activity in the heart experience much more cardiac complications than those without this increase. And strikingly, no such difference is observed in men. So there are sex differences in the impact of this increased cardiac sympathetic activity. So could sex hormones explain this difference between women and men? In this animal experiment, which was conducted in our team, female and male mice were divided into two groups: normal mice, who still had their sexual organs, testicles for male and ovaries for female, and therefore still produced sexual hormones, so testosterone for male and mainly estrogen for women. And the other group consisted of mice in which the sexual organs were removed, and in whom, therefore, the production of sex hormones dropped. So what we observed is that in normal female mice, so who still had their ovaries, the cardiac sympathetic activity, therefore the nervous activation of the heart, increased with age. So here, young females and aged females. So there's an increase with age, similar to what I described earlier in human beings. Whereas in the mice in which the ovaries were removed and who therefore produced no estrogen, there was no clear difference between young and aged females, which implies that female sex hormones, here estrogen, has an influence on the nervous activation of the heart, the cardiac sympathetic activity. Now about inflammation. So it's important to know that the stress we experience in our daily lives leads to an increase in the inflammation levels in our bodies. In a relaxed state, what has been observed is that levels of inflammation are increased in young women, here in red, compared to young men, so similar age, here in blue. And when subjected to an acute episode of mental stress, there's an inflammatory reaction in the body, so an increase in the inflammatory markers in the body, which is much more marked in young women compared to young men. And it has been shown that the higher the inflammation in our body, the lower the blood supply to the heart is. So the arrival of blood via the coronary arteries to quote unquote feed the muscle of the heart, so which is called the blood supply. So the higher the inflammation in our body, the lower the blood supply to the heart is, which means the higher the risk of heart attacks. Therefore, stress has an impact on the blood supply to the heart. So biological differences related to the nervous system of the heart, the cardiac sympathetic system, to sex hormones, to inflammation, but also gender-related differences. So classically, heart attacks manifest as a chest pain behind the sternum, irradiating to the chin and the left shoulder. But this is the classic representation of heart attacks in men. And actually, women present more atypical symptoms, such as shortness of breath, nausea, tiredness. In addition, several studies have shown that women tend to wait longer than men to seek medical attention. So both of these factors lead to an increased risk of missing the diagnosis and of delaying the treatment in women compared to men. And there are also biases in the way we as medical doctors treat women. So studies have shown, for example, that women who have heart attacks tend to receive less invasive treatments than men. What I mean by invasive treatments is that usually when we have a heart attack, a myocardial infarction, it can be related to an obstruction of the artery that brings the blood to the heart muscle. And usually one of the mainstay treatment is to insert a catheter in the artery to go to the heart, to go to the coronary artery, so the artery of the heart, and to deobstruct it, to open it. And it has been shown that for similar types of heart attacks, of myocardial infarction, women tend to benefit less from this technique than men. So, and in addition, so we know that there are some traditional risk factors of developing heart diseases, such as diabetes, hypertension, smoking. But there is an increasing recognition of non-traditional risk factors, such as depression and mental stress, and which have been shown to be overrepresented in women. So indeed, women have been shown to perceive greater stress after heart attacks, and also to have more complications after heart attacks. So how could stress be interconnected with the heart? In this important study, the authors investigated the link between a brain region called the amygdala, and which is located somewhere here, and cardiac health. So the brain amygdala actually is a region of the brain which is involved in the control of emotions, such as fear and stress. And the more stressed or the more negative emotions we have, the more this brain area, this brain area will be activated. And we can explore the activation of the brain regions with this nuclear medicine technique. And basically, the more intense the color is, the more the brain area is active. So for example, here, for the patient on the left, we see that there is no color, no activation of the amygdala, which indicates that this patient probably wasn't a very stressed patient. Whereas the patient on the right, we can see here clearly this color, this intense color. So an activation of the amygdala indicating an activation of the brain region of stress, and therefore a stress patient. And so here, similarly to what I showed you a couple of slides ago, so we see two curves. The red curve is related to the population of people with activation of the brain amygdala, and therefore people with stress, mental stress. And the green curve relates to people with no activation of the brain amygdala, so non-stressed people. And the lower the curve, the more cardiac complications over time. And we can see here clearly that people who are stressed develop much more cardiac complications than people who are not stressed. So mental stress is related to heart attacks, which strongly suggests that the brain plays a role in the development of heart attacks. So we could hypothesize that a possible explanatory model could be that an increased activity of the brain area of stress, the amygdala, could be associated with an increased activation of the nervous system of the heart, the cardiac sympathetic activity, and also an increased inflammatory response, so inflammatory levels in the body, which could in turn induce increased heart diseases. The question is now, does biological sex, in particular sex hormones and female hormones, play a role, and do gender also play a role in this loop? And this is actually the purpose of a study we're currently conducting here at the University Hospital of Zurich. So for this study, we are recruiting healthy women and men aged between 50 and 70. Why this 50 threshold? Because actually we want to focus on, for the case of women, on postmenopausal women. And just to give you a brief overview of the design of the study. So the study starts with questionnaires to evaluate the personality, because we could, as Sarah explained, we could belong, quote unquote, to a certain biological sex, but either identify or at least display personality traits of what is classically considered as the other sex. So being a man and having, quote unquote, female traits, and the other way around. And also to assess if there are signs of depression or whatever. And afterwards, we assess the blood supply to the brain and the heart. So how blood and oxygen is brought by the arteries to the brain and the heart using an imaging technique. And we do it in a relaxed state at rest, and also following a mild stress. Basically, it's mental calculation. And the idea is to see here if there are differences between women and men in the reaction of the brain and the heart to stress. And afterwards, we assess the activation of the amygdala following another type of stress, and also compare it between sexes. And in parallel, we collect blood and saliva samples. So if you're interested, or if you know anyone who might be interested in our study, so we started it actually in October 2021, and it will last until the end of 2022. It takes place in our department in Schlieren every Monday morning. And if you are interested, would like to have any information, please feel free to contact us either by phone or by email, which are shown here. And I would be more than happy to answer all of your questions. So thank you for your attention. And I also wish to thank my whole team, which is led by Professor Catherine Gebhardt, you can see here. And also in particular, Dr. Susan Banks, Dr. Alexia Rossi, as well as Dr. Valerie Traya, who are working closely on this project with me. So thank you for your attention, and I would be happy to answer any of your questions.
Thank you very much, Nita, for also this very interesting talk. I think it's really cool that we have two people from very different sides, one from more the humanity and one from really the medical side. And there are a lot of questions to both of you. I think I have a question for you, Sarah, first. And that's about, like quote, I guess doing non-binary medical research would make research inefficient, but more exact. What's your opinion about this inefficiency?
Well, I think it's always important to, just have everybody, really everybody in mind, and meaning like the body. And I would say that this is not inefficient, but it would just help maybe, I mean, I'm not a physician, but I think it sometimes would also help clarify like what also Nida made strong in his talk. So is it about the hormones, or is it about gender or anything? So yeah, I would say that like broadening the idea of studies and broadening the idea of like what is a man, what is a woman, and not thinking in binary terms would just make research stronger, and could also help people more efficiently, more efficient.
Yeah, and maybe I would like to add something. So to be schematic, I talked about biological sex, but even on the biological level, it's not that obvious. I mean, from an embryological point of view, we can have, like, for example, male cells and still not produce, because there's an inactivation of the gene that produces testosterone, still not produce it. And from the birth, not to display any male sexual organs or any external signs of being masculine, despite having XY cells, meaning male cells. So it's not that obvious to classify, even biologically, what is male and what is female. So it's probably much more complex than that. And this is where the gender studies are interesting.
And maybe a question for both of you. Are there like things we could easily improve with the modern medicine by taking gender into account in a better way? And are there any recent developments to do this? Maybe Nida, you can start.
Yes, sure. So yeah, actually, there's a lot that could be improved, and this is why what I think is exciting and interesting about the projects we're working on currently. There is increasing awareness, but probably not enough, and it's really important to focus on it, because as I've shown in my first slide, this has really not taken into account sex and gender, has a direct impact on the health of the patients, because basically now we're treating the whole population, including the 50% of women, based on what has been discovered or described, or what functions in men, because they constitute the majority of people who are included in the studies. So we're probably treating a lot of diseases wrong because we just included the wrong population for study design reasons, etc. But now that we are aware that this has an impact on women, this obviously needs to change.
I totally agree, but I would also go one step back and would say that it's also really, really important to educate future physicians, and to give them the idea what's the difference with female and male patients. For example, also when a woman comes to the doctor's office, how she tells her pain, for example, that already there's I mean, there are studies that women talk about pain differently than men, for example. And I think it's really important to give an idea that there are differences, and that when you are a physician, that you should really listen and not think like, oh, well, okay, the woman talks and after 10 seconds, I don't listen anymore. And I mean, that's what happens in doctors' offices. And I would say that this is the problem. And I would say, I mean, this is only with cis men and cis women, but especially when you're not like fitting into the binary terms, then it gets even more complicated. And I think it's really important for now physicians, but also for future physicians to get in touch with that already in their studies. And for example, I conducted a seminar last semester where I focused on that. I mean, I'm a historian of medicine, but still the students were really happy. For example, we also were talking about FGM, so female genital mutilation, which they never heard of before in their studies. And I mean, that's super important, just to recognize what is it, like how to deal with the people who may come to our offices. And I would say that this is also really, really important, like really to focus on people who are studying medicine and give them an idea that other people are maybe different than they are themselves and to listen.
Yeah, exactly. I mean, I think this education of the medical community also should be broadened probably to the whole society. I remember there was this campaign a couple of years in France about how heart attacks manifest in women, trying to raise awareness about this. And since it came from, it was sponsored by the medical community, it helped bring the message to the whole society. And I think it's really something that needs to be done at all the levels of society. So I totally agree with you.
And for you, Nida, do you think that the general medical approach is already changing and considering more gender differences, or is it still like a niche research area?
Well, I think there are two things. First of all, I mean, the medical community is quite conservative, I think. So it takes time to change. Though I wouldn't say that, yeah, we're pretty much advanced and everyone is aware about it. I mean, I myself have been working on this project for 1 year, and I have to say that I really started discovering the topic. I mean, I knew I had some general cliches, general ideas, but I really was made more sensitive to this topic just by working on it. So I think there's a lack of awareness in the medical community. So yeah, clearly I mean, as I said, we're a conservative environment and this needs to be changed.
And do you have any ideas how that could be done, like in an effective way?
Well, so for example, here in Switzerland, there's this like probably a chair of gender medicine, which will be developed. I mean, it's still not effective, but it might be in the future. I think it needs to be brought in the medical studies. I mean, medical students need to be made aware of it. And since gender medicine affects all the components of our sex and gender medicine, because it's both components, affects all the strats of health, this should be really like displayed in all the atmosphere of medical studies. And also another problem that we have is this confusion between sex and gender that I also made until quite lately, actually. Understanding that yes, there are some biological differences, and this is where sex-related differences, whatever the disease is, are important to know because there are differences, obviously, and not to confuse it with gender studies that try more to see what might be artificially created by society as differences and which is not really present. And these two components should be clearly explained and not be confronted as opposite to each other, but both be used to understand more what's happening.
And may I add something? I think it's also really important to keep in mind that gender medicine is not about only women, because I think some people think like, you know, gender medicine, it's only about women, blah, 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 but they don't understand, some people don't understand that gender medicine is also about men. So it's about the question, like what is biologic, what is biologistic, and the question, what are the differences between men, women, and how can we approach them in everyday medical life? And I think that's really important because especially, sorry to say, but especially sometimes male physicians are like, gender medicine, well, I've heard about it, but, you know, it's only about women. And I'm like, yeah, you know, that's completely wrong. And I think that's a stereotype that really needs to, be destroyed. But yeah.
Yeah, that's a really good statement. And I think this talk will help to destroy this image of gender medicine. And there's a question to you, Sarah. I mean, you mentioned the European history and the views of them. Do you know anything about the distinction between male, female, or penis, vagina in non-European cultures, for example, Chinese or Mayan?
Yeah, that's a really interesting question. Unfortunately, I don't know that much about it because my own research focuses on Europe. But what is really important, and I mean, yeah, I also only quoted people from, let's say, the Western cultures. It's really important to say and to keep in mind, especially in indigenous cultures, that there is not the gender binarity we have in the Western culture, right? Because, for example, especially if into people or people who are not either male nor female, they have really important roles in the societies. For example, I don't know, they're healers, or they have they're connected to cultural, religious things, or were, because the problem always is that yeah, the Western culture, colonization happened, and quite many of the cultures were destroyed, and the idea of how a body works and also how society works was brought there. But basically, in many indigenous cultures, it was different, and that's also why I think it's really important to bring that knowledge back, or to bring the idea back, to say, hey, there is more than a binary gender term.
Thank you. And there's also a specific question for you, Nita. Are there things we can all do independent of sex and gender to improve our cardiac health? And for you, has learning about cardiac health changed your behavior?
Okay, so not related to sex gender differences. Okay, well, there are what is already known, like eating healthy and doing sports, etc. But something which is probably not well known, and I mean, hopefully with the study that this different studies on this topic, including the one we were conducting about the role of stress, I think we're not aware enough that it has really direct impact on our health. For example, there is this disease. Well, it has a Japanese name because it was first described in Japan, called Takotsubo syndrome. Usually it's referred to as the broken heart syndrome, which was for the first case is described in women, in postmenopausal women, but it also affects men. So basically, it's people experiencing an intense emotional stress. So the first cases that were described were like in postmenopausal women getting divorced in Japan. So it was an extremely intense negative emotion, and who developed symptoms of what everything looked like a heart attack, but basically the arteries were not closed. So it was another mechanism. And this disease, which is quite well known now, really showed the direct interaction between the brain and the heart. So maybe on top of what is already known in terms of heart prevention, food, sports, etc., maybe this component needs to be more emphasized and improved.
May I also ask you something, Nida? I would be really interested in the term stress. So what is actually stress? Because, in your talk, that was the thing that I was really interested in. So when does stress start, or what is, yeah.
Yeah, so actually it's like all the, I'd say, subjective studies, for example, people who want to study the impact of yoga or whatever. So these studies where you have to rely on how people express their experience, but you cannot really measure it. So you have two things. We use questionnaires to evaluate them. So there are some validated questionnaires, but based on the subjective expression of what people feel. And luckily now with these imaging techniques, these what we call functional imaging techniques, so basically nuclear medicine, it's called functional imaging because we look at how the cells and the organs function. It helps us to put a biological reality, let's say, behind these subjective expressions of what people feel. So I agree with you, it's difficult to say what stress is because it's basically a very subjective experience. So yeah, these questionnaires are quite well validated. And what we're seeing now from these nuclear medicine techniques and also functional MRI techniques that it's not just a subjective experience of the spirits. There's something really happening on the organic level. So yeah, it's difficult to say what stress is. I guess it's really, really personal. I mean, for I see it in our study now that we're conducting. Some people would rate their stress like 1 or 2 on 7 for the stress that we perform, and other people say no, it's awful, it's 5 out of 7. So it's really personal and subjective. So it's a bit difficult for me to answer you.
Okay, then I think it's already time for the last question, and that's one for you, both of you. And that will be, what do you hope will change in gender medicine during the next 10 or 20 years? Or what are your wishes for this gender sex discussion in our society? Maybe Sarah, you can start.
Yeah, that's a really good one. I hope that quite much changes, that, you know, that everybody knows the difference between sex and gender, and that everybody knows that like all that sex and gender are so different and can be various, and that people are accepted the way they are. For example, you know, no matter who you're born, that also, for example, especially when you go to the doctor, that people understand your problems, that they listen to you, and that you're treated yeah, well, and yeah, not yeah, so just not the way it is today. So that when you go to a doctor's office, that you that people help you and that they take you seriously. I think that's the thing that I wish the most, actually.
Yeah, I totally agree with Sarah. I mean, there's this need for like really to change the mentalities. And as Sarah mentioned earlier, I mean, some maybe older male doctors, physicians have this impression that, yeah, it's a woman thing, but actually it's a matter of public health. I mean, it's not a woman thing, it impacts us all. I mean, so yeah, I would hope for this confusion about women thing, conservative, whatever archaic behavior could be replaced by just acknowledging that there are differences and there are things that are common, and we need to work on it just to improve public health. And that's all. It's not a question of ideology or dogma or whatever. It's a reality. We have to work on it.
And do you have also any recommendations to read more about this topic, about gender medicine or gender or sex differences?
Yes, I have a book that's super cool. It's written by Cordelia Fine, and it's called Delusions of Gender. And everybody who's interested in neurology and the question of like, so many people say, you know, this is typical for women and this is typical for men. And the book is so great because she, you know, she just shows that it's just not true. And yeah, it's also really scientific. So if you're really interested also in good studies and who works on the field, this is a book to read, Delusions of Gender by Cordelia Fine.
Well, given Sarah's enthusiasm about this book, I probably wouldn't have a better advice to give. So I'll leave the advice to Sarah.
Okay, thank you very much for this interesting discussion, also the excellent talks. It was really cool to have you here. And of course, I also want to say thank you to all the people in the background here in the meeting, Vanessa, Laura, and Joel, who also organized many things. And of course, to the audience for the attention and also the very good questions. And of course, if you like these talks, you may also like other nanoTalks. You can find those directly here on YouTube. And the next nanoTalks will be on the 24th of February. Yeah, it's 24th of February, about direct democracy. I think it will be also online via YouTube. So have a nice evening and thank you.